The motivation behind it was I was interested in the way the systems of care work in the UK and where the money goes and how much we spend on end-of-life care. And that gave way to a cost of care study, which many health economists will be familiar with. We do a lot of cost of care type studies to sort of gauge the impact of and the scale of the work that's being done. My particular approach I call an evidence synthesis and simulation approach, and I'll explain why that is as we go along. So my research question for this study was, what is the cost to society of caring for people with cancer at the end of their lives? I chose cancer because, in a sense, it was the easiest disease area to study. I also had intended to do dementia, but as you can see, the challenges I had with cancer alone, you'll understand why I didn't eventually try and tackle the cost of caring for people with dementia. So I'm interested in the healthcare costs, social care costs, so not just NHS costs, but what happens in social care. It's a massive factor in end-of-life care. Charity care costs. As I'm sure you know, a lot of care at the end of life is provided by hospices, and that is predominantly a charitable sector process. Lots of work with the NHS, but so much of that funding comes through the charity sector. Informal care costs, again, an area where a lot of the care that people get comes from their loved ones, particularly spouses and children and sometimes other family members and friends. And the one thing I didn't manage to include in the study was direct costs to patients, which is unfortunate. And as a theme that will run throughout this presentation, there's a real problem with data and understanding how much patients are spending themselves to get the care that they need. So how much are they contributing in terms of things like, even little things like that we might hear about all the time, parking charges when you go to hospital, transport, taxis, things that may seem small on the scale of the health system, but actually are quite big to the individual patients and their families. Unfortunately, not able to include that. So why is it important that we know how much we're spending on end-of-life care? Well, we want to understand the resources that are spent on particular types of care. How does the NHS budget of £100 billion plus pounds, where does it actually go? We know which regions it goes to, and if we look really hard, we can find out which areas of care it goes to, but how much in particular, and is it appropriate given the scale of the need, patient need? So the only way we can know if we're spending enough in the right places is to know how much we're spending in the first place. I wanted to identify the different contributions of different sectors to the overall care that people get. So how much is going into healthcare, how much social care, how much of that care is provided by charities and informal carers. And I think it's important to help plan for future care needs as well. So if we know how much we're spending now and we can project out into the future what we're expecting in terms of demographics and the population, how much more we're going to need to put in. Okay, so problems. Well, two major problems I came up with in this study trying to work out how much we're spending on end-of-life care. First of all, I couldn't find a nice, handy, standard research definition for end-of-life. What is end-of-life care? And secondly, we don't have very good data as a general rule. There are specific areas where we have good data and research effort is increasing all the time and we're getting more trials and stuff, but at a population level we have very little data and we don't know what's going on with it, typically. So this is paraphrased from a famous Supreme Court decision, actually about obscenity from the 1960s, I think it was, where the Supreme Court in the United States couldn't agree. They all agreed that something wasn't obscene, but they didn't agree at all on why. And one of the judges famously said, "I shall not attempt to further define what I understand to be embraced within that shorthand description," and I'm paraphrasing for end-of-life care here, "and perhaps I could never succeed in doing so, but I know it when I see it." And that seems to be, in many respects, a lot of what we do. We know when we're dealing with end-of-life care. We know when we're researching it what it is and what we're doing. But if you wanted to set a definition ahead of time, you'd really struggle. And that was something I came up against because I wanted to identify ahead of time which patient group I was looking at. Who are the end-of-life patients with cancer? Well, I can't just go to a data set and say, right, this patient is marked end-of-life, this patient is it. And maybe in future that will be possible with the gold standards framework and the surprise question and so on being recorded in GPs, but we don't have access to that data today and it's not routinely collected. So we can't use data sets to identify end-of-life patients until they have died. So, for example, the Nuffield Trust published a study in 2012 and a follow-up in 2014 looking at the costs of end-of-life care, and they used 12 months as end-of-life period, and I'll show why that's a problem later on. But they couldn't do that until they'd already identified the patients once they have died. And the problem with that is, once they have died, it's not easy to determine how long they might have been end-of-life per se, how long they would have needed palliative care. And I'll just say, from my perspective, when I'm referring to end-of-life, I am thinking mostly about people receiving palliative care, somewhere on that spectrum of, no longer really thinking about cure, but palliation. So we don't know how long those people in the Nuffield study needed end-of-life care. So really their study wasn't of end-of-life care, it was of the last 12 months of life. So there is a distinction, and it's quite important. So no routine data. We can't identify the patients, so it's hard to collect that routine data. So we can't just go and say, this is a set of cancer patients, here's how much we did with them, and that's the cost of end-of-life care. We don't know then what happens at the population level, because we can't pick those people out from a data set and say, look, in this area, this is what's happening, in this area, that's what's happening. It takes a lot of work on the ground. Without routine data, we also can't devise a tariff. So in the NHS, a lot of activity is paid for by tariff. You do something, the CCG pays the trust based on your activity. But if you don't know how much you're doing, it's hard to set a cost. And the tariffs are set according to trust activity and cost data. So there's no, unless it's changed recently, there's no tariff for palliative care. And there was a pilot set of work about finding a tariff for palliative care, but I don't think it ever got into practice. I don't actually know what happened to that. Tom Hughes-Hallett work. And without a tariff, services may be seen as less important. There's no payment from the CCG for a particular activity, and so it's harder to justify it. Some trusts I know have got local tariffs agreed with their CCGs, their payers, and they're able to introduce palliative care in different ways, but for some trusts maybe they don't have that, so it's harder to justify the services that they're receiving. And from a researcher's point of view, it's hard to then just say, well, we spent this much per patient on palliative care, there was this many palliative care patients, therefore this is how much we're spending. And that's only in the health service. Social services, charity sector, informal care, of course, all these problems even larger because they don't collect any kinds of data in many of those areas. So why does it matter? Well, as I said, to estimate the cost of care, you need data on the size and characteristic of the population and the cost of their care. The other thing is trying to work out which care is end-of-life care and which care just happens at the end of life, which is potentially problematic. A lot of care for patients with comorbidities, they would get even if they weren't going to be, even if they weren't dying. But you can't really decompose that from the data. You can't really look at that and say, this is care that happened because they were dying, and this is care that they would have got anyway. So that's problematic as well. So we can't identify these patients. It makes it really hard to work out what we're spending. So I just want to give you an example now of a typical cost of care study that was very closely related to the one I was doing. It came out of Oxford, I think in 2014 by Luengo Fernandez and all, et al. The economic burden of cancer across the European Union, a population-based cost analysis. So they had a different population. They were just interested in cancer patients, not end-of-life cancer patients. So they were looking across Europe, and they had information about the total number of contacts for cancer patients with each type of service. So every time a cancer patient got treated at a hospital as an inpatient or outpatient, it's recorded in the data sets, and they can look and see what it says. They can work out how many of those contacts were for cancer, because they might have been going for other conditions as well, but because cancer is a nice, easy thing to define, they can get it in and say, this is a cancer attendance, it's an oncology outpatient, it's an oncology inpatient, and so on. And they can work out the unit cost. So in the NHS, the unit cost for an oncology outpatient appointment is known. So you can just add those up. 10 oncology outpatient appointments at £150 each, £1,500 in a year. Easy, relatively speaking. So, and they got a total cost of care of 126 billion euros. So we spend quite a lot of money on cancer care, no matter how you slice it. It's going to be a pretty big chunk of money. Okay, so those were the challenges I faced, some of the challenges I faced, and here are some of the solutions we came up with. So no standard research definition. First thing to do was define what I was counting as the end-of-life period, because that determines the rest of the decisions, and it determines what data must be collected. So once you know how you're defining your population, then you can set in motion all the things you need to do to collect your data and decide how you're going to analyze it. As I mentioned before, the Nuffield report used end of life as the last 12 months of life. So did the report from the National Audit Office, which is a bit older, I think about 2008 maybe. They did a big study as well, looking at that. And that's nice because it ties in as well with the surprise question that is part of the gold standards framework, and that I think QOF points are associated with that now as well. So we should maybe get some data on that. But of course, it's not necessarily the most specific and accurate question, but it's a start. The trouble is, with this approach, some patients have very, very different needs depending on what sort of diagnosis they have. So, lung cancer patients, the mean survival from diagnosis is the mean survival from the time they start strong opioids, which I'll come to in a minute, is 180 days. Whereas for breast cancer patients, it's 372 days, so twice as long. So you can see that using 12 months as your defining point means that for some patients, you're going to be overcounting. So lung cancer patients you wouldn't necessarily want to add up 12 months of their costs because that's not related to their end-of-life period. And for breast cancer patients, yeah, that's about 12 months, but that's the mean. So a lot of those patients are going to be living longer than a year. So you've got that problem as well. So for some patients, you need to count for longer than a year, and for some patients, shorter. So a study from Guest looked at the end-of-life period as the point at which patients begin strong opioids. Their argument was that it's clinically relevant for end-of-life care. This is the point where care is directed more towards palliation than it is necessarily to cure. And from my perspective, that can account for the varying lengths of time with patients with different illnesses will spend as quote-unquote end of life. And of course, nicely for research purposes, it's a tractable problem. We can identify the patients then and we can address the issue. Now, that's great for cancer patients. It may not work so well in other populations, but so another one of the reasons why I didn't end up pursuing the dementia angle in this work. No routine data or tariff. Again, so we can't use the approach used in the example I gave on European cancer costs. The alternative approach, it's evidence synthesis approach. So the health economists in the room will know what I mean. A sort of decision analytic model in a way. Taking together all sorts of disparate pieces of information and trying to combine them to make one picture of what's going on. Almost like a decision tree, if you're familiar with that sort of decision-making thing. So combine a wide range of evidence and combine within an economic model. So taking data from the Nuffield report, taking data from the ONS, taking data from the hospital episode statistics and the published literature and putting it all together. But that generates a whole series of new problems as a result. Because then you have to decide how you're going to combine all this data. You've got to make a whole range of assumptions. And also that data is quite often very uncertain. So you get a whole other range of problems, starting with the modeling approach. So it allows the aggregation of a wide range of indirect sources, but it creates uncertainty in the model structure. How do we put all this together? How do we trace the cancer patient pathway from the time when they start to enter this end-of-life period through to death? And how do we do that in a way that is relevant to as broad a range of patients as possible? What sort of data do we include? Healthcare data, social care data, the informal care data. And there's uncertainty in the data. So you take an estimate from the published literature, so from the Guest paper or the Nuffield paper, but then that's only a sample, so you've got some uncertainty there. You don't know exactly what's happening, whereas with something like the HES data, you've got you can be much more confident about the quality of the data and the uncertainty around it. But one of the benefits of this approach is that we can then quantify how uncertain we are. So that was one of the main things that I took from this paper, is that even though we'd have a lot of uncertainty, at least now we can get a grip on just how uncertain, and we can focus some efforts maybe on, from the economist's perspective, reducing some of that uncertainty for future research. So, structural uncertainty, assumptions about types of care people receive. I already mentioned this, end-of-life care versus care at the end of life. Social care versus health care. What fits into where? So much of end-of-life care happens at the margins of these types of work. So what is healthcare and what is social care? Because that matters for how you cost it and how you assign activity. Formal versus informal care. Does informal care substitute for formal care that's needed, or is informal care there to make up for formal care that isn't present? Inpatient, outpatient, and community care. Where is this activity happening? Because that again matters. If it's happening in the community or as an outpatient, that has different costs than if it's happening as an inpatient. Particularly in some areas, one thing that I meant to put there but seemed to have forgotten was charity care. So Mary Curie hospices and other hospices, they raise money through fundraising to support their work, but they also receive payment from the NHS. So how do you assign that cost in your model, and how do you deal with that? Because it does make a difference. Do you cost it as Mary Curie's cost or as an NHS cost, for example? Links between different data sources. How do these different elements of care relate to one another? How do we bring this data together? The decisions you make there, they also drive the uncertainty in the results. And the covariance between data. We know that, if a patient uses a lot of services of one type of service, they're likely to use a lot of another type of service, perhaps. But there's no way of knowing necessarily exactly how. So in a sense, you have to treat all of your data as independent, even though you know that it's varies with one another. So I'll give an example of that later. So this is a bit tricky to see perhaps, but this is just the model structure that I ended up using, the basic idea. So you start with a patient and you think about the probability of a resource use. So perhaps an inpatient stay. In the last year of life, 97% I think of people are an inpatient in hospital in some capacity. The volume of resource use, so how many inpatient stays. I was able to, I chose to adjust that according to their expected survival as a patient. So if they were expected to survive for half a year, then I took the data that I had for, say, a year and adjusted it to be half a year. Again, a problem with adjusting there because the data actually doesn't just evenly happen over a year, but we have data for a year. So, there may be some things going wrong there that feed into that uncertainty. And then you get some unit cost for that activity, which gives you a patient cost, and then you get a total cost across your population with some measure of variability, some measure of dispersion. Because I use a particular simulation method, I've got credible intervals rather than confidence intervals. So this is the same thing again, but in a slightly different way. So probability of resource use and quantity of resource use, expected survival, taking the data from the literature, from the routine data, and expert opinion, which is the least good kind of data source that we can have in a model, but in some cases that's the best we have. And then the same then, but just a slightly different way of showing it. Talked about those structural assumptions, and then a little bit more about this, the data. So this is a screenshot from the actual Excel model that I used for the analysis. And you can see here that what I did was, this is the prostate cancer group. So The mean survival was 360 days from the start of strong opioids if you have prostate cancer. What I wanted to do was know what, if you sampled a large range of patients with prostate cancer, what would be the survival? So you take a sample from the data, you define it as a distribution rather than as a point estimate. You take a sample and it gives you a value of 183 in this case. So this patient in my simulation survived for 183 days, which then goes into the calculation for how much they cost. So the mean survival, that should say mean, not median, but was 360 days. This patient survived 183 days. So I adjusted their costs like that by 0.5. Does that make sense? If you do have any questions for clarification, just let me know. And then that can be applied to a particular resource use. So if you see here, 4.88 contacts with the district nurse would be if they survived for a year. So adjusting half of that in this case. So that's there. So again, no routine data. Data in the literature, as I've mentioned, only partially reported in many cases. So we've got this mean days, but without any measure of dispersion. So actually, I don't know, the mean and the interquartile ranges or any other, the 95% confidence intervals. So I had to make some assumptions again around that, which feeds through into the results, as you'll see later on, in terms of the uncertainty and the broad spread there. And of course, as I mentioned, it's not possible to adjust for covariance between the inputs, even though I could adjust crudely for survival. But just to take an example, that same data, that same example, the mean estimate in the literature for the number of contacts in the last year of life that a patient with prostate cancer had, that I found, was 21.76. When I sample it in my model, I get for the GPs in this instance 35, and for the district nurse about 5. But you can think that a patient who needs to see the GP a lot probably also needs to see the district nurse a lot. But I don't know what that exact relationship is. So I've had to treat them as independent, even though I know they're not, because that's the most conservative assumption. And so in reality, if that's 5, this is probably not 35, because they're probably not as poorly as that. But we don't know. Maybe I'm wrong. Maybe it's because they're at the GP all the time that they're not seeing the district nurse. That's the other side.
One of them might be a phone contact, one might be a face-to-face.
It could be. Because the data is not there to say exactly what kind of contacts they were, we don't know. So I think it's probably that they should be closer together, but maybe they should be that way. So like I said, I've made the conservative assumption that they're independent, but that filters through. Reliant on a few key data sources. That 2012 study I mentioned did at least provide a lot of data on activity, and I've been able to use that. Hospital episode statistic data is available at a population level for cancer patients, which I've had to then make assumptions about end of life. ONS data to figure out how many people died from each condition. NHS tariffs and unit costs. The PSSRU, Personal and Social Services Research Unit across Kent and LSE and Manchester, I think now as well. They publish each year a very handy guide on unit costs for health and social care, if anyone ever needs any of that sort of data. And from individual studies. So for example, from the GUEST study, I was able to extract some data on the total cost of drugs that patients use at the end of life. So trying to pull all that data together into a single model and use simulation methods to deal with that uncertainty. So what I did was what we call a Monte Carlo simulation, which takes the data, instead of defining it as a single point estimate and saying this is what it costs, it's a distribution. So this is the range of things that happen. And then you sample that 10,000 times. So you effectively do your calculation for 10,000 different patients. And then, well, that's a sample of the distribution. So you can't really see it because it's a bit fuzzy. But We know that there was that many patients who had a hospital appointment out of that total population, and then that gives a total probability of the event happening. So I was able to do that, and I was able to do some one-way and scenario analysis, and you'll see the advantage of that later. So results, finally. So in the paper, these are the results that I presented. And importantly, you can see from the credible intervals exactly how much uncertainty we have. So for the average breast cancer patient, I estimated just over £4,000. But in the simulations, that ranged from £395 to £12,500. So that could be to do with any number of factors why that is. Some of it will be the uncertainty in the underlying data. Some of it will be the fact that for some patients they lived a long time, for some patients they lived a very short time. But I think what that flags up is, because we have such uncertainty in the data, it doesn't actually tell us very much about how much we're spending on care that happens to people at the end of life. And you can see that that feeds all the way through. So for breast cancer, the total care that is got a value of £12,600, but ranges from £1,200 to £38,000. So you can see it's massively uncertain what we know. This particularly applies to informal care, because we know that there's lots of informal care that goes on, but it's very poorly recorded in the data, and there's very little research on how much informal care. There's lots of research on informal care, but to find out how much care an actual patient receives from their loved ones is really difficult. Yes?
Jeff, how did you value informal?
So the non-jargon explanation, I used to value informal care, I looked at the hours reduced in employment, or the hours of time spent caring, and I multiplied that by the average wage. There's lots of different ways that it can be done, but that was the one that I could do for this study. So it's, So the other way, another approach might be to use the cost of replacing that informal care with formal care, but that assumes that all that informal care needs to be provided by a formal care provider as well. So the informal care, we know lots happens, but we know very little about the detail of it. So, for example, I used data from the British Household Panel Survey for another study on informal caregiving. I know how many hours of care an individual provides to somebody else, but that doesn't tell me how many hours of care the recipient receives, because they may get care from different sources and from more than one person. So if the person in my data set provides care to their mother or father, and so does their sibling, I know one side of that equation but not the other. So it's really tricky to find out about informal care, and if I were to focus on some of that research, I'd like to know a lot more about that particularly. Another interesting result was the charity care, and I know there's someone from Mary Curie in the audience, but several. And I was a bit surprised how little this factored into the overall cost of care, because of the profile of the hospice movement in particular, and Mary Curie and Macmillan and all sorts of charities that are targeted at helping people with cancer and helping people at the end of their lives. I mean, on reflection, it makes a good deal of sense. People spend very short periods of time in hospice relative to how long they're ill. But actually, the value of that care in pounds is probably far less than the value of that care to society. So I thought that was quite interesting. And again, it's very variable, because only a very small proportion of people actually end up in a hospice. I think the base case estimate I had was about 5%. Now, most of those are still cancer patients, so in terms of this study, that figure will be much higher for this study than it would be if I had done the dementia patients as well. And then, as you can see again, social care, massive variability because unlike for healthcare, where at least we have some routine data like the HES, even if it's not the ideal definition of our patients, there is not very good routine data on social care. It's really hard to find out what happens. And that's one of the reasons I drew on the Nuffield study so strongly, was because they had managed to get access to 7 local authority worth of social care data, but that's probably the best social care data set going, and it's not publicly available, unfortunately. So we might have to nobble them. Yes?
So the charity care, is that just inpatient hospice care?
That is primarily inpatient hospice care, because the other care, we didn't really know enough about who was getting care in the community. So it's primarily inpatient hospice care, but that's where a lot of, I think, the costs are as well, because an inpatient day in a hospice is quite expensive.
And you mentioned earlier there's a choice to make between, do you score it as the cost of the NHS or the total cost of care? Which would you go for?
For the inpatient care, that was for the charity. So I put that to the charity. For social care, there was some element of that I assume was within the actual sort of home care that people got. I don't know if it's in my... Sorry, I'm going to go back a bit. Maybe I shouldn't have done this. No, it's not. And it's not even there. I thought maybe I had put some of the social care data up, but it was only the healthcare data. So that's the overall result. So on average, I'm estimating about £10,000 per person at the end of life if they have one of these 4 cancers. I would expect that wouldn't probably be different across the whole other range of cancers, but again, these are the 4 biggest. I think they account for between 40 and 50% of all cancer-related deaths between them. So again, a reason why I chose them, the best data available. This is the total cost of care. So the estimate, £641 million being spent just on these 4 cancers for people at the end of life, as I've defined it. So, so for all the people in the last 12 months who died, to care for them in the last period of their life cost society £641 million. And a third of that cost is borne by informal caregivers, so a huge sum of it, depending where in the variability you think we land. Because it's either virtually none or a massive amount. So it all depends. Right, so what does it all mean? I probably have to speed things up a bit. Advantages to this approach. Capture and communicate this uncertainty. That study that I mentioned on the European data, they just provided an estimate of 129 million. They broke it down by country, but they didn't say we think this is between 129 or 120 billion and 140 billion, and our best estimate is 100. They just said it's 129 billion. So I think that this has an advantage over that because it reflects that we just don't know what's happening. It's adaptable. Using this method, we can then look at different things. What happens if? What if we decide to increase the amount of hospice provision? Or what if we change the balance between health and social care provision? What's going to happen then? And we can explore in detail what's going on as well. So some examples. This is those results by patient with the interquartile ranges from the sampling. You can see, sorry, for breast cancer, this is breast cancer informal care. The interquartile range covers almost the entire mean cost. So it's massively uncertain. The total costs we're a little bit more certain about. Healthcare costs, more certain about. Informal care costs and charity care costs, really uncertain. So just so you can see, like that just reflects what's going into the model and how uncertain we are about the data. Scenario analysis. Okay, this is hospice care at 5%, hospice care at 20%. We can see, of course, it would expect it to go up. with some more sophisticated analyses, we could change other variables. If there's more hospice care, perhaps there's less inpatient care, so we'd expect the healthcare thing to perhaps go down. And perhaps the total cost of care to go down, because hospice care is less expensive in many cases than hospital inpatient care, especially if patients are in an ITU at the end of life and getting all sorts of intensive treatment that they really maybe didn't want when they could have been in hospice. So it's adaptable, so I think that's a strength. And we can look at the detail as well. If you were to just look at the overall results and say, wow, lung cancer, it must cost a lot to treat a lung cancer patient because they're clearly the largest group. Well, actually, they're the largest group because they're the largest group in this, they're the highest cost because twice as many lung cancer patients as any of the other cancers. So per patient is actually quite low. And that's because they die very quickly, because once you've got lung cancer, your prognosis is very poor. So we can look at that using this method, whereas perhaps in that other approach, the more top-down approach, we couldn't do that as easily. Disadvantages, I think I've said these plenty of times throughout. Very high data requirements. You need to pull together a lot of data. You can't just look at a data set and go, A multiplied by B. Limited by the data quality, the independence of the data sources, and there's a higher probability of making mistakes because I'm using a complex Excel spreadsheet model type device, and it's really easy to just type something incorrectly in a cell and get it wrong, and then embarrass yourself in front of the whole world like those chaps who did that all around the banking, Rogoff and others, if you remember that a few years ago. Possibly not, if you're not economists. So thank you.